Thank you, Pratik. Um, Chronic kidney disease carries a high risk of mortality and is associated with multiple comorbid conditions. Diabetes is the leading cause of CKD, which develops in approximately 40% of patients with diabetes worldwide. And in the US, diabetic kidney disease accounts for 38% of new cases of end-stage renal disease. Importantly, CKD is a recognized cardiovascular risk factor associated with an elevated risk for coronary artery disease, heart failure, arrhythmias, and sudden cardiac death. Cardiovascular disease, rather than end-stage kidney disease, is the leading cause of death in this high-risk patient population. Cardiovascular events are significantly higher in patients with early stages of CKD, as well as in patients with advanced CKD, and this risk is further elevated in CKD with diabetes. The prevalence of CKD is increasing, and CKD is now recognized as a global public health problem, imposing huge medical and financial burdens on society and healthcare systems. So with that in mind, there's been a shifting paradigm around treating it, including sort of government and payer incentives and policies lining up, guidelines, screening, treatment recommendations and options, and so forth. And in the shifting landscape, it's important that everybody be rowing in the same direction. So that sort of sets the stage for our discussion today. And I'll go ahead and give Dan a little bit more of an intro. So he received his Doctor of Medicine at Rush Medical University in 1974 and completed postgraduate training in internal medicine, hypertension, and nephrology, and a renal research fellowship at the Cleveland Clinic Foundation in 1979. He's held academic and clinical appointments at Cleveland Clinic Foundation, Bowman Gray School of Medicine, Wake Forest University, and at the Mayo Clinic, Mayo Medical School. In addition to 27 years as a practicing nephrologist, Dr. Wilson has held a variety of industry roles in cardiology and nephrology space, including at Pfizer, Relipsa, KPP Biosciences, and most recently joined Bayer Pharmaceuticals in 2020 as a senior medical director and cardiorenal strategist and subject matter expert. He's continued to be involved in clinical research on cardiorenal disease and hypertension. So Dan, I'll let you go ahead and run away with it with our next slide here.
Well, Jonathan, what you said is that I'm an old guy, and so I've been around for a long time. So before I start, in most presentations, I like to ask the question, why are we doing this? And let me tell you why I'm doing this at this point in time. I practiced nephrology for 27 years. I did full contact nephrology, dialysis, transplantation, clinical nephrology, and hypertension. And I had to sit across from patients who had diabetes and presented to me with end-stage kidney disease secondary to diabetes. And I had to place them on dialysis. And that occurred fairly frequently. At that time, I knew that dialysis was a life-saving therapy. I also knew that it would have a significant impact on their quality of life. But what I also knew, and which was difficult to share with patients, was the fact that 50% of them would die within the first year. Now that's improved a little bit over the last several years, but still there's a very high first-year mortality with dialysis. And when I saw that as a nephrologist, I said, I need to become a preventive nephrologist. So could I go to the first slide, please? So let's talk a little bit about kidney function and such. We measure kidney function by taking a look at glomerular filtration rate, how blood is filtered through the kidney. Now, normally after when you get to be 55 or 60, you start to lose about 1 ml per minute per year in terms of estimated glomerular filtration rate or the filtering ability of the kidney. Patients with chronic kidney disease, however, have accelerated deterioration and progression of disease. They may lose up to 5 mils per minute per year. And this is the case in patients with poorly controlled diabetes or uncontrolled diabetes. We now have the therapies that enable us to reduce that and reduce it to generally between 1 or 2 mils per minute per year. And what this does is it increases survival and prevents many patients from getting to end-stage renal disease. On the right-hand portion of the slide, you'll see that we're also going to be talking about proteinuria. And proteinuria is a marker for progression of kidney disease. And we're going to get into that in detail in the future. Next slide, if you could. So on this slide, I wanted to point out and follow up on what Jonathan presented earlier, that CKD identifies a high-risk population for cardiovascular disease. And in this particular slide, what you can see in the light blue is the frequency of myocardial infarction. And in dark blue, what you can see is the frequency of heart failure across normal and the other stages of kidney disease. And what you can see is as the stage of kidney disease increases, as kidney disease worsens, there's an increased rate of myocardial infarction, there's an increased rate of heart failure. And when you take a look at normal to those patients who have advanced kidney disease, stage 4, stage 5 CKD, there's a 5-fold increase in terms of the risk of heart failure. So one of the important things to remember is that kidney disease identifies a high-risk patient population for cardiovascular events. Next slide, if you would. So this is the patient journey that we would like to see. And the patient journey not only involves nephrologists, it involves primary care physicians, endocrinologists, and the whole team that treats the diabetic population. What we'd like to see is early diagnosis, and that early diagnosis has to occur at the level of the primary care physician. We want to see early intervention to prevent progression of disease. This could be a preventable disease if we act very early. And then when patients that have advanced disease, we need to have a multidisciplinary collaboration to treat them effectively and to preserve kidney function. Next slide. So what are the problems? Well, we have several gaps that basically interfere with us being able to initiate effective treatment in patients with CKD and diabetes. We've had guidelines for years. Over the last 10 years, we've had 6 major guidelines that have come out and given us recommendations, guideline directed medical therapy, and on how to treat these patients, how to diagnose them, how to treat them. But there are multiple gaps. The first gap has to do with testing. Many of the patients that have diabetes are not getting tested. And screening, when it's done infrequently. It's not done on a yearly basis. Not only that, but we're coding inappropriately. We don't have the ability to follow these patients because the diagnosis is not made. They're not coding appropriately. And your institutions or your practices are losing money when they're not coding this effectively. And finally, many people are not getting on the effective therapy. When we take a look at ACE inhibitors and ARBs, which are clearly recommended in patients with CKD and diabetes, less than half of the patients are on an ACE inhibitor or an angiotensin II receptor blocker. And finally, if you look at the top there's another major problem that we have, and that problem is recognition. Patients don't recognize the concept of chronic kidney disease, and only about 10 to 12% of patients know that they have chronic kidney disease when they have CKD. So there's a real need for patient education in terms of as we move forward with eliminating these gaps. Next slide, if you would. So we talked about screening, and screening is actually very simple, but it's not done frequently. It involves a estimation of glomerular filtration rate, and now this usually comes on most laboratory profiles, an EGFR, and it gives us a rough idea, again, of the filtering capacity of the kidney. The other test, which is frequently neglected, is the UACR. This is a spot urine for albumin, and it's an albumin creatinine ratio. Generally should be done in the morning, but it could be done later in the day. It doesn't have to be a time specimen whatsoever. There's been clear recommendations for the last 10 years by the American Diabetes Association, KDIGO, that's the Kidney Disease International Global Outcome Group, as well as the KDOKI group, recommending that we do this on a routine basis in all patients who have diabetes. And there's some suggestion that we should be doing this in high-risk patients who have hypertension. Next slide. So why is it important to measure both of these? Well, here we're taking a look at a 10-year risk of mortality in patients with type 2 diabetes. Here we see no kidney disease on the left-hand side. And as you can see, if you have albuminuria, you have a 2-fold increase in terms of your risk of death over a 10-year period. If you have an impaired GFR, 2.7-fold increase in terms of risk of dying. However, when you combine both of those together, you get the best risk assessment, and those patients that have albuminuria and impaired GFR have a 5-fold greater risk of dying. So it's important to do both of these parameters and to use them to help classify the stage of kidney disease. Next slide. Now, this is a complicated slide, and I don't want you really to get upset about this over here. The real important factor of this slide is in the blue box over there. In patients who have CKD and who have greater than 300 milligrams of albumin in their urine, a reduction of 30% or greater with medications and treatments will slow the progression of kidney disease. This came from a workshop that was developed by the National Kidney Foundation, the FDA, and the EMA, the European Medicines Association. So that we've recognized for years that proteinuria is a marker for kidney disease, but reducing proteinuria actually delays or reduces progression of kidney disease. And so there's been some objection to this particular using this in a guideline. The ADA uses this in their guideline, but when you talk to many nephrologists, they say you shouldn't stop at 30%. You should go get the maximum reduction in proteinuria in these particular patients. Next slide. So how do you put this all together, the eGFR and the UACR? Well, this is what was initially developed by the National Kidney Foundation called the heat map. And it's now basically the KDIGO heat map. And with permission, the ADA has adopted or adapted the KDIGO heat map. On the left-hand side, you'll see the different degrees of glomerular filtration reduction. It goes from normal to kidney failure, stage 1 to stage 5. You know, nephrologists are a little finicky, so we do divide the stage 3 into stage 3A and stage 3B. And the reason is that when you take a look at patients with stage 3, stage 4, and stage 5, these patients are on the slippery slope, and they're really apt to progress more rapidly. The second part of the KDIGO heat map has to do with albuminuria. If you have a UACR or albumin excretion less than 30 milligrams per gram of creatinine, that's considered to be normal or near normal. If you have moderately increased albuminuria, and that's 30 to less than 300, that's considered to be A2. And if you have severe increase, which is greater than 300, that increases your risk, and we classify that as A3. In general, I say normal, high, or very high when I look at this. Now, if you take a look at this algorithm, there are two other things that have been added to it. First of all, there are recommendations that indicate that patients should be on treatment, and they give you some idea when patients should be referred to a nephrologist for additional care and follow-up. And on the bottom of this over here, you'll see that not only the color coding over here actually identifies a level of risk, and we'll talk about that in a minute. So it's important to get both of these parameters to use the heat map to classify the patient and code things appropriately. The other thing I want to point out is there are patients out there, and we need to identify them, that have eGFRs or glomerular filtration rates above 60. And if they have a moderate increased albuminuria or severely increased albuminuria, these patients should be treated. And in some cases, they should be referred. So we're not dealing only with patients who have marked reduction in eGFR. We need to identify patients early, because I think, again, early stage kidney, if we identify early stage kidney disease, we can prevent more progression of kidney disease and reduce cardiovascular events. Next slide. So taking a look at those risk categories, and we're taking a look at them in patients without diabetes and with diabetes, you can see that as the risk profile increases, there's again a dramatic increase in all-cause mortality, so that patients with very high KDIGO risk have a five-fold increase in mortality. And that increase in mortality is not only related to end-stage renal disease, but it's related to cardiovascular events. Next slide. So you might say, well, we've been testing urine for years. Why can't we just use a dipstick? And in my training, I used dipsticks for years. But I can tell you, it's very difficult to tell the difference between trace and 1+ and 1+ and 2+. And what we find out is that when you use a dipstick to classify or to make note of the protein in the urine, that there's generally an underestimation of the amount of protein that a patient is spilling, underestimation of the amount of protein, and it could account for misclassification. So the point here is that we're abandoning dipsticks and going to the UACR. Next slide. So how are we doing And you know, I was a fan of Ed Koch, and Ed Koch used to be the mayor of New York. And one thing that Ed did as a politician, I really reveled in. And he used to walk down the street and look at people and say, "How am I doing?" So we have to ask ourselves, how are we doing? And here we're taking a look at a study done by the National Kidney Foundation, a study that took a look at 466 primary care clinics. And what they did is they went into these clinics, classified the patients, and asked the question, how many of these patients were classified or coded as having chronic kidney disease? And these were patients with diabetes and hypertension. And they found out that only 12% of the patients were coded appropriately. And why did we not recognize the fact that these patients had a higher frequency of kidney disease? Well, in many cases, the UACR was not done. And in some cases, the EGFR was not obtained. So the point here is if we don't do the screening, we're not going to identify these patients and we're not going to get them on proper therapy. Next slide. This is a study that came from primarily the West Coast of the United States, done by Kathy Tuttle, called the CURES trial. And what she did is she took a look at 81,000 patients with diabetes, and with and without diabetes. And she asked the question, how many of these patients had an EGFR as well as a UACR? Virtually 92% of the patients had an EGFR, but only 9% of the patients had a UACR. Now, this has improved over the years. This is a fairly recent study, but I would say now that somewhere on the order of 30 to 40% of patients in the US with diabetes are getting a UACR, at least one UACR. Next slide. So what happens if you do this screening and you invoke or develop a care plan? This is a study of over 7,000 patients in which the National Kidney Foundation classified these patients as having CKD and put them on a care plan. And what they looked at in this particular study is, can you reduce healthcare costs? And you can see across the board for class 3, class 4, or stage 5, the CKD, there was a reduction in hospitalizations. And so that this, if we identify these patients, treat them appropriately, importantly, we can prevent progression of disease and cardiovascular events, but we also could save our healthcare system valuable dollars. Next slide. Now, what about treatment? Again, how are we doing? We're not doing fairly well. As I mentioned earlier, only 30 to 40% of patients with CKD are on an ACE inhibitor or an ARB. That's increased a little bit from 2006 all the way up to 2017. But the fact of the matter is that there are more people on potentially nephrotoxic agents such as proton pump inhibitors and NSAIDs than there are on protective therapy. And SGLT2 inhibitors, although being recommended for years, are not heavily utilized in this particular population. Non-steroidal MRAs, again, which are now recommended, are not heavily utilized in this particular population. Next slide. And this gets back to one of my first slides. The point here is that most people are not aware that they have CKD. In fact, when you take a look at patients with CKD stages 3 to 4, only about 10% of them are aware of this. And so there's a real need for patient education. And you might get tired of some of the TV commercials, but they're educating people about CKD. And I think that's important. As you develop a greater renal impairment, then patients become aware of the fact that they have a risk for dialysis and such. But the risk for CKD is clearly under appreciated when you take a look at people's appreciation of hypertension and diabetes. Next slide. So what have we done about this? Well, the NKF, National Kidney Foundation, and NCQA have partnered to develop a measure which has now been adopted by HEDIS and now has been further adopted by CMS. And this is going to be a value-based healthcare evaluation measure. And the measure is that you're going to be, that programs are going to be asked to report the percentage of patients of over 18 years of age and up who with type 1 and type 2 diabetes who have received appropriate screening, an EGFR and a UACR. And in value-based programs, there'll be penalties if you don't do this, and so that your reimbursement would be reduced. So there's been general recognition that we need to be more aggressive in terms of screening patients and screening them appropriately. Next slide. One of the things I didn't mention and skipped over was the fact that when you screen patients, if they have advanced kidney disease, they may require multiple screening, because we need to see whether or not albuminuria is going down or going up to adjust therapy. So patients with advanced kidney disease may be screened up to 4 times per year. So how are we doing in terms of coding or making the diagnosis? Well, many of you are familiar with the NHANES study, the National Health and Nutrition Examination. And when they did careful testing on a sample of US Americans across the length and breadth of the United States, 37% of patients had CKD. But when we take a look at Medicare registries, only 14% have CKD. So there's under recognition and under coding. We need to know more about these patients. They need to be coded appropriately. And when we see those codes, we then can go ahead and ensure that they're on the proper therapy. Next slide. There are codes now in ICD-9 and ICD-10 for different stages of kidney disease. And these are the codes here. We need correct documentation on these patients to ensure that patients are receiving the right diagnostic studies and the right therapy. Next slide. So let's take a look now at guidelines. I mentioned that we've had 6 guidelines over the last 10 years. Well, within the last year, we've had 3 guidelines. So one from the American Association of Clinical Endocrinologists, another one from the ADA, and another one from KDIGO. In general, the ADA and the KDIGO guidelines are generally the most accepted guidelines. Next slide. So let's take a look at what the ADA said. Well, the ADA is now pointing us to take a lesson from cardiologists, and they basically put together pillars of care. When you treat, these are complicated patients. And if we're going to reduce diabetes complications, we need to focus on glycemic management. We need to focus on blood pressure and reducing inflammation in these patients, inflammation and fibrosis. So we need to focus on lipid management to reduce cardiovascular risk, and we need to use additional CV agents as necessary for CV and kidney benefit. And the baseline for all these pillars is lifestyle modification and diabetes education. Next slide. So let's take a look at the updated guideline. By the way, the ADA will update their guidelines up to 2 times a year. And this is the latest guideline. What they do is, again, a strong recommendation for screening patients with a UACR and an EGFR. And what they point out over here, again, if you have advanced kidney disease, you should be monitored between 1 and 4 times per year, depending on the stage of the disease. Next slide. They, again, emphasize the pillars of care: optimized blood pressure, blood glucose control, optimized blood pressure control. Either an ACE inhibitor or an ARB is recommended for those with moderately increased albuminuria or severe albuminuria, and you use the maximum tolerated dose of an ACE inhibitor or an ARB. So they should be up titrated to get the maximum dose in these particular patients. Next slide. When you're using an ACE inhibitor or an ARB or an MRA, it's important to periodically monitor the serum creatinine and potassium to make sure that there's no adverse effects or risk that's associated with these medications. And we're going to have to revise our thoughts about this. Don't discontinue these medications willy-nilly. If the serum creatinine goes greater than 30% or the EGFR decreases by 30%, consider stopping the medication, maybe giving the patient a drug holiday and resuming them at a lower dose. Next slide. SGLT2 inhibitors have been clearly shown to reduce the progression of kidney disease and cardiovascular events. SGLT2 inhibitors, GLP-1 receptor agonists, and non-steroidal MRAs all have the potential to reduce cardiovascular risk. They do this a little differently. The SGLT2 inhibitors and the non-steroidal MRAs have a much stronger effect on heart failure and cardiac death, whereas the GLP-1 receptor agonists have a greater effect on reducing atherosclerotic events. Next slide. So in people with chronic kidney disease who have persistent albuminuria or albuminuria, you can decrease progression of kidney disease using a non-steroidal MRA. And this is a new addition to our armamentarium. And not only does it reduce progression of kidney disease, it reduces cardiovascular events. And then finally, the ADA still has the recommendation that if you have greater than a UACR of 300, you need a 30%, you need to target for a 30% or greater reduction in UACR. Next slide. So this is a KDIGO guideline, and we're not going to spend a lot of time on this over here because it's very similar to the ADA guideline. ACE inhibitor and ARB are recommended. SGLT2 inhibitor is recommended. Non-steroidal MRA is recommended. There's only one non-steroidal MRA, and that's finerenone at this point in time. This shouldn't be confused with spironolactone or eplerenone, which either have contraindications and both of which have never shown benefit in terms of reducing progression of kidney disease. They do have an effect on proteinuria. Next slide. One of the reasons why we might not have seen a greater utilization of an SGLT2 inhibitor, because you needed to do an assessment on patients. You need to introduce these in a thoughtful manner, and you need follow-up on here. So the KDIGO has basically included this particular diagram in their guideline to help clinicians think about the issues that surround prescription of an SGLT2 inhibitor. Next slide. There are also similar concerns that you have with non-steroidal MRAs. You have to make sure that the patient is appropriate. They can be combined with a RASI and a SGLT2 inhibitor. In order to mitigate the risk of hyperkalemia, you need to have patients that have a serum potassium of less than 5 milligrams, 5 millimoles per liter. And again, they're recommending here in KDIGO that you choose a non-steroidal MRA that has documented kidney and cardiovascular benefit. Next slide. So that was a lot of stuff. It was a lot of guideline. But here's a simple way to put it together. For the first time, the ADA and KDIGO got together, and they basically harmonized their guidelines, and they came up with a holistic approach towards treating patients with CKD and diabetes. This focuses on the pillars of care. The first pillar, again, is lifestyle modification, a healthy diet, increasing physical activity, smoking cessation, and weight management. The second pillar is glycemic control. You can either start with an SGLT2 inhibitor or metformin. If you need additional glycemic control, GLP-1 receptor agonists are recommended, or other medications if necessary. In terms of blood pressure and hemodynamics, patients should be on a maximally tolerated dose of an ACE inhibitor or an ARB. Dihydropyridine, calcium channel blockers, and other medications may need to be added for additional blood pressure control. A non-steroidal MRA is recommended for patients irrespective of their glycemic control or blood pressure if they have a UACR greater than 30 milligrams per gram of creatinine. That's a new addition to this particular algorithm. And finally, very importantly, we need to put these patients on appropriate therapy to reduce cardiovascular risk. All of them should be on a high-intensity statin, and if necessary, antiplatelet agents should be utilized. Next slide. So I told you what I was going to tell you. I told you what I was going to tell you, and now I'm going to tell you what I told you. CKD associated with type 2 diabetes is under-recognized and under-screened due to low patient and clinician awareness, and documentation is inadequate. UACR and eGFR should be used properly to stage patients, and if we don't do that, we're going to miss the early stages of kidney disease. Both EGFR and UACR are predictive of CKD progression. Interventions that we need to remove barriers to screening. We need to make this more routine and a part of general medical care. And finally, we have new classes of medications that have been proven to be effective to delay the progression of kidney disease. We can reduce it from 5 mils per minute, maybe down to 2 or 1.5 mils per minute. We can reduce, and importantly, we can also reduce cardiovascular events in type 2 diabetes. The best way to deal with this, I think, is the holistic approach to addressing the pillars of care, and is currently and these are currently recommended in the guidelines, and this should be the major focus for guideline-directed management and treatment of CKD and diabetes. So I thank you for your attention, and I'll give it back to Jonathan.
Thank you, Dan. So I'm going to hand over screen control to Dr. Vora, and while we do that, I will introduce him as well. So Dr. Parag Vora earned his medical degree from the Maulana Azad Medical College and is a board certified in both nephrology and internal medicine. He has over a decade of clinical experience and most recently practiced as a nephrologist at Beth Israel Lahey Medical Center. He developed an interest in chronic kidney disease, and population health, and currently serves as the medical director for Monogran Health. Dr. Vora.
Thank you, Jonathan, and thank you for the warm introduction. And thank you, Dr. Daniel, for a wonderful presentation. So I'm moving on to the pathophysiology, and then we will be discussing few trials to consolidate what Dr. Wilson said previously. So we all are familiar with this slide. We are familiar with the structure of a glomerulus. We know that it's fed by an artery called, or arteriole called afferent arteriole, and drained by efferent arteriole. And to simplify the pathophysiology of kidney disease or diabetic-related kidney disease, most of its effects is on the efferent arteriole. And now you can understand, if there will be a constriction of efferent arteriole, there will be increased kind of a hydrostatic pressure within the glomerulus. And usually from the glomerulus, you should not be leaking larger molecule like albumin, a little bit larger than the electrolyte, right? So usually you should be having electrolyte filtration like sodium, potassium, and water. But when the pressure increases to a point that you start leaking the albumin, it causes the significant damage to the glomerular structure. And once the significant damage happens, then you start progressing into the chronic kidney disease. That's a simplified pathophysiology. So the most of the treatment plan, or most of the treatment or most of the medication we target to reduce the hydrostatic pressure so that the leakage of albumin does not happen. And this apparatus kind of saved for the longer duration of time. So in a layman answer, if you want to know, like how can we reduce the pressure? You can reduce the feeding vessel's flow or constrict the feeding vessel, or you can dilate the draining vessel, right? If you prevent the blood from, or lower the blood from entering into the glomerulus, that's going to decrease the pressure. Or if you're going to knock down the blockage or dilate the efferent arteriole, that's going to reduce the pressure. So this is how the mechanism works. And moving to the next slide, that's what it shows. So the efferent arteriolar constriction is the first thing which happens. So once the constriction happens, then the hydrostatic pressure goes up, and once the pressure goes up, the albumin leakage starts, and the glomerular hyperfiltration starts, and eventually it leads to the cellular injury. And that's what we are protecting with the new mechanism, with the new medications, and that's where we are targeting, right? So why this is challenging for all the primary care physicians and the nephrologists to diagnose diabetic nephropathy at early stage. The problem with the early stage diabetic nephropathy is, hypothetically, I'm a diabetic patient and I started developing the diabetic related kidney changes. The first change happened to my kidney will be that I will be going into the hyperfiltration stage. So once I'm entering into the hyperfiltration stage, I will also filter the creatinine down, right? So there will be more filtration of creatinine. So my creatinine will go down and my GFR actually is going to go up. So how can I diagnose, when my GFR has gone up from 90 to 110 with the diabetes, right? So it becomes very challenging. And at that time, the albumin leakage hasn't even started. So in that stage, it's difficult to diagnose, but the problem is by the time the overt diabetes related kidney disease happen, you have already lost 20 or 30% of the battle, right? By the time overt diabetes happens, when your GFR starts decreasing or creatinine starts increasing, there is significant damage to kidney. Does the comes first, or does the albuminuria comes first as a marker? The answer is very clear. The albuminuria precedes the rise in the creatinine or decline in the GFR, only because it is related to the hyperfiltration, right? So by the time the creatinine decreases or the GFR, by the time creatinine increases or the GFR decreases, there is a significant damage, and that's why more and more nephrologists or researcher and primary care physician are targeting albuminuria as a first target. And a lot of people ask me, why you are so obsessed with the albumin leakage, right? What is the albumin leakage a marker or a therapy target? The albumin leakage has become kind of a therapy target because there is no other way to lower the albumin leakage than to lower the hydrostatic pressure in the kidney, right? So as long as I can reduce the pressure in the glomerulus, I can reduce the filtration of albumin into the urine. And there is no other way to know, how much or how good I lowered the pressure in the glomerulus than to see the albumin leakage. So that's why urine protein creatinine ratio should carry so much weightage, and that should be the take-home message. We do not want a point, when the GFR is slightly declined, but the patient is leaking 2 gram or 3 gram or 4 gram of protein in the urine, because we know what's going to happen. These patients are at a very high risk, and they're going to progress to the end-stage kidney disease faster than the people who do not have albuminuria. So coming back to the treatment, just like Dr. Wilson said, when I was in my residency and early stage of my fellowship, we were told only about 2 important clinical trials, and these both trials were focusing on the ARB and ACE inhibitor and how good they are in slowing the progression of kidney disease. And we are not doubting that ACE inhibitor and ARB are not good medications. They work wonderfully well. The challenge here is that they leave us with a significant amount of residual renal disease. Just like what Dr. Wilson said, so if your GFR today is 100 and you are full-blown diabetic with a proteinuria kidney disease, you can lose around 7 points of GFR within 1 year. So if you are losing 7 points and I put you on the ACE inhibitor and ARB, so instead of from 100 to 93, you may go 100 to 95, but you're still losing the 5 points. So instead of having end-stage kidney disease in 15 years of the diabetic lifespan, you will have an end-stage kidney disease at 20 years of lifespan. So you get some protection, but think about our patient population, right? Our patient population is the 45 and 50s when they start becoming diabetic and diabetic nephropathy. You protect, and then the way that you lose your GFR, you end up having end-stage kidney disease at 65 and 70. You put them on an ACE inhibitor on ARB, you add on 3 or 4 extra years, but that's not enough, right? So ACE inhibitor and ARB were in the market for last, 20 years, 15 years. We were using them fairly well, like even 30, 40, 50% penetration in the market, but it did not slow down the progression. Right, like the disease is progressing. Right now, I can tell you the data. We have around 600,000 patients on dialysis. And if we don't do better, or we don't change our treatment plan, or we don't utilize all the resources and take care of all 4 pillars, which Dr. Wilson explained, we will have 1.2 million patients, or doubling of the dialysis population in 2030. So we have to stop this kind of a epidemic building of the CKD, which has multiple other polychronic diseases, because with the CKD comes the cardiovascular disease, comes with the peripheral vascular disease and all that stuff. So, and the era of last 15 years before we had SGLT2 inhibitor and other new drugs were very depressing. And when I say it's depressing, means like there were multiple clinical trials about the newer medication to slow down the progression of kidney disease, but all the trials failed. We had like a direct renin inhibitor trial. We had a trial in which people used the ACE inhibitor and ARB together, and there are smaller other drugs. None of them has shown effective benefit of slowing the progression of the kidney disease. So the point came in last 5 years, and the last 5 years are probably I would say last 3 or 4 years are the best era in the treatment of diabetic nephropathy, because we have found something which actually slowed down the progression to a point that I can add probably 15 to 20 years without dialysis, right? So if somebody will have end-stage kidney disease because they lose like 4 or 5 points every year in their GFR at 70, I can protect them from not getting dialyzed till the 90 year of age. Look how wonderful job I did with the newer medication. Keeping in mind, I should still focus on blood pressure control and diabetes control and all of this stuff. So the first medication, like in this scenario, which I will be talking about, is the SGLT2 inhibitor, right? The landmark drug, which has changed the management of the diabetic nephropathy significantly. We all know how the SGLT2 inhibitor works. It works by blocking the SGLT2 receptor at the proximal tubule. And once it blocks the proximal tubule SGLT2 receptor, it causes flush or a filtration of glucose and also the sodium. And there are multiple other mechanisms through which SGLT2 inhibitor works, but the end result is the same. And the end result is lowering the filtration pressure by dilating the drainage vessel or dilating the efferent arteriole. So once the filtration pressure reduces or the hydrostatic pressure reduces in the glomerulus, the protein leakage gets lesser. And once the protein leakage gets lesser, you save your kidney for the longer period of time. And that's so much different than what SGLT2 inhibitor were introduced for. So this is a classic example of what has changed from bench to market about the SGLT2 inhibitor, because the bench, they were marketing, initially they were introducing the drug for lowering the glucose, but now the kidney protection and their cardiovascular benefit has taken the center stage. And so much has changed, and so much we know about the SGLT2 inhibitor now. So I'm going to move on to 2 important trials regarding the SGLT2 inhibitor. One is called Credence trial, and I think the whole nephrology practice changed from here onwards. And so the Credence trial was a trial about patients who have a chronic kidney disease, about 4,000 patients who have significant proteinuria and who have the GFR between 30 to 90. So they placed patients on SGLT2 inhibitor, canagliflozin or Invokana. It reduced the protein leakage significantly. You can see within the first 6 months, there's a major drop in the protein leakage. And as long as you keep SGLT2 inhibitor on board, the protein leakage has been lower than the placebo. If you compare with the GFR, most of the patients who I put on SGLT2 inhibitor have sudden drop in the GFR. And the reason is the SGLT2 inhibitor causes natriuresis, that also causes the glucose dumping. And because of both of them, you have a volume reduction, you can have a pre-renal kind of a picture, but that recovers very nicely. And down the line, SGLT2 inhibitor protects the kidney for the longer period of time. And these were such a good medication that, they had to halt the trial in between. And the reason they halted the trial was, there was absolutely no reason to give the patient placebo. They said, you're doing a disservice to the patient, giving them the placebo, not giving them the SGLT2 inhibitor, because the benefit was so obvious, right? And now how are we doing in the community? Like when these FDA and all the clinical people who are reviewing this stops the trial in between because they know the beneficial effects, how we are doing about the SGLT2 inhibitor in our community. We have only 9% penetration. That means only 9% of the nephrologists, primary care physicians are inhibitor lower down the protein leakage. I think we can do better. We all can do better as a team, as a clinician, because we know the obvious effects. We know that it slows down the progression. And the next question you're going to ask me, Parag or Dr. Vora, how much slowdown in the progression you're talking about? Buddy, I'm talking about slowdown with the ACE inhibitor somewhere between 13 to 15 years. So the same patient which we discussed, who was diagnosed of having diabetic nephropathy at age of 45 or 50, was supposed to get dialysis at 70. He's not going to get dialysis 85. If we do some better job, we add on the non-steroidal MRAs, or we add on the GLP agonist, we probably will prolong to 20 more years, right? So you have done your job. You have prevented the patient from entering into the dialysis. You have also prevented all the cardiovascular morbidities and mortalities, like the patients get an MI or peripheral vascular disease and recurrent hospitalization. And you have prevented patient from entering into the dialysis, which is a $100,000 elephant, right? All the patients, the patients once enter into the dialysis, just for the dialysis procedure, I'm not talking about the hospitalization. I'm not talking about the amputation and all, and infection and all that stuff. The dialysis itself causes $80,000 to $100,000. So how much money you have saved for the healthcare system, me coming from the value-based care, just doing a small intervention of putting a patient on SGLT2 inhibitor, along with ACE inhibitor and ARB. And so that's the importance of the newer medication. And that's why we all are talking. We understand now the target albumin leakage because there is no better marker than the albumin leakage, and then put them on the ACE inhibitor, control their diabetes well, and utilize the newer medication, because the newer medication are the game changer in slowing down the progression of the kidney disease. So moving on to another trial, there was a little bit of a confusion when the SGLT2 first trial came, or Credence trial came. People thought like this may be related to their glucose lowering effect, right? They're seeing a beneficial effects in the kidney because of the glucose lowering or diabetes control. So the Farxiga in 2020 published another trial in which they said it does not matter if you have diabetes or not diabetes, as long as you have proteinuria from any cause. It may be hypertension related proteinuria, it may be secondary FSGS and obesity related proteinuria. Any proteinuria, you're going to place these patients on SGLT2 inhibitor, you're going to do a service to the patient. You're going to make their kidney better protected for a longer period of time. So they saw the similar results. I'm not going to go to the detail about it because of the time, but they saw the similar results, right? There is an initial drop, which is expected, and then there is plateauing of decline to a point that you add on 10 to 15 years in the patient's kidney expectancy. Another important trial, which I want to mention, which I did not here because of the time restraint, but I want to discuss. Recently, there is another trial called AMPA Kidney published, and AMPA Kidney tells us, like when we did the two initial trials, Credence and DAPA CKD, we were not using SGLT2 inhibitor below the GFR of 30, 30, right? And with the AMPA Kidney, so they have started using SGLT2 inhibitor for the GFR in the range of 20s all the way towards the dialysis. So now you can use SGLT2 inhibitor when your GFR is around 20, and you can continue the SGLT2 inhibitor till the GFR goes down or the patient goes to the dialysis, right? It still slows down the progression. We do not use the SGLT2 inhibitor with the GFR of 15 or 10. The reason being, there is so much of a fluctuation at the early months. I don't want somebody having GFR of 12 and you start the SGLT2 inhibitor, and because of the pre-renal phase initially drops down to 6, he becomes urinary, goes on dialysis. So that's the reason, you're not going to use that. You're not going to start somebody on SGLT. There's no hard and fast guideline, but you probably will not start at a very low GFR. But I think it's safe to start at the GFR of 20, let patients stabilize with the initial fluctuation, and then the continuation of the SGLT2 inhibitor till the patient gets on dialysis. You're going to still have a better cardiovascular outcomes, better hospitalization prevention, and the better and the slowing down the progression of kidney disease. So from here onwards, the take-home message is, if the patient can tolerate combination of ACE inhibitor and SGLT2 inhibitor without any contraindication, we should maximize the utilization of the drug, right? Now, there are some contraindications, there are some side effects. We already discussed that there is a hypotension associated, and the hypotension is because of the pre-renal kind of insult, initial dumping of the water. The infection is a major one, either the urinary tract infection, Fournier's gangrene. Have I seen any Fournier's gangrene? I did not yet, but I never say never. The bone fracture, I don't think it's a very big deal, but amputation and peripheral vascular disease definitely is. You're not going to start somebody who has a peripheral vascular disease or who has kind of a recurrent urinary tract infection or a genital infection or very significant hypotension, just like the patients of cardiorenal, and for which, we're going to discuss the non-steroidal MRA. But if you have a cardiorenal, and you're on Entresto and you're already bottoming down your blood pressure because of Entresto, probably do not start SGLT2 inhibitor. If your potassium is good, we will move on to non-steroidal MRA, and I'm going to talk about it in a second. So we so far covered important things. We covered about how important it is to know the albuminuria at the early stage, because that's the only marker which tells you how good is your hydrostatic pressure in the glomerulus. We talked about the renal and IGNT trial. We talked about how the ARB protects, but they leave you with significant residual renal disease. And then we talked about SGLT2 inhibitors, and we talked about the Cadence trial. And then we said, like if we put these patients on SGLT2, we're going to prolong the life expectancy and have a less cardiovascular outcome. There is the third mechanism, which, and Dr. Daniel Wilson is an expert, but I'm taking a courage to talk about this medication because I'm going to continue this conversation about the medications. So the non-steroidal MR inhibitors, or the mineralocorticoid receptor overactivation, is another problem you see in the kidney disease patients, because once the MR gets overactivated in the diabetic patients, there is more pro-inflammatory markers and more fibrosis to the kidney. And we have seen that, like blocking the MR receptor, and now with the specific, the non-steroidal M1 specific receptor, you have documentary evidence or a clinical evidence of slowing down the progression of the kidney disease. So I'm going to go, and we know the drug non-steroidal MRA, the drug name is Findrenon. And I'm going to review 2 trials, and actually going to combine both 2 trials into a pooled analysis. So there were 2, non-steroidal MRA had 2 clinical trial designed. One was Figaro and the other one was Fidelio. So the primary outcome in Figaro was lowering the endpoint, mainly focusing on the cardiovascular, and Fidelio, the endpoint was the kidney protection. And actually going to both trials separately, but they did is they pooled the data, and that pooled data, I'm going to be presenting it to you in the next slide. So, the idea behind was, so this patient should be on the maximum tolerated dose of ACE inhibitor or ARB, and then you're going to add on the Findranon on the patients, whether they are on the SGLT2 inhibitor or they are not on SGLT2 inhibitor because of some reason, right? So when they took the patient, this is very interesting. So they took the patient who are either the moderate risk or a severe risk of progressing into the kidney disease, right? These are the patients who are having a heavy proteinuria. They took like 200 patients or less, who have a mild proteinuria or non-proteinuric, because a non-proteinuric, we now know after this 1 hour talk that they don't even progress, right? If my GFR is 1.5 and I have no protein leakage, my prognosis is excellent. We're not focusing on that. We're not going to design a trial in that, right? So we're going to design a trial on a patient who have a protein leakage of greater than 300 or at least between 30 to 300. So large amount of patients were a high risk kidney disease patients having a heavy proteinuria. And also the important aspect of it was, that these patients, 40% of the patient had actually the higher GFR, like you don't even diagnose the kidney disease, right? When the GFR is greater than 60, these patients have a good GFR, but these patients had a protein leakage of around 300 milligram or above, So this trial definitely tells you, how significant is the lowering the protein leakage, because, like a lot of patients here were not even classified as a CKD based on the GFR alone, unless you combine the GFR and a proteinuria. And look at that, 67% of the patients here in the trial has the protein leakage greater than 300 milligram per gram of creatinine. So they studied the primary cardiovascular outcome, which I'm not going to go into the details, and the kidney protection outcome. This 57% decrease is a composite endpoint because like all the kidney trials tells you, when your creatinine jumps double from 2 to 4, you have an average decline of 57% in the eGFR. And so rather than saying the doubling of serum creatinine, they are saying eGFR decrease of 57%. And the Findranon, you see the same placebo and Findranon, you have significant reduction in the doubling of serum creatinine. And they have shown a significant improvement in the cardiovascular composite outcome, reduction by 14%, and reduction in the kidney composite outcome by 23%. And even more interesting is, there were a subgroup of patients who were already on SGLT2 inhibitor, and they added the Findranon on top of it. There is a 37% reduction, which is, we need to do, I don't know, when Dr. Wilson is going to explain it to us, if there any other trial with a combination of both, but the subgroup which were on SGLT2 inhibitor and Findranon together had a 37% risk reduction. So which patients I'm going to use Findranon on, like very obvious, like if the patient is not a candidate for SGLT2 inhibitor because of recurrent infection, peripheral vascular disease, or I'm targeting a cardiorenal kind of a patient in which I need to lower the hypertension, have a better cardiac protection, or just add on the top of SGLT2 inhibitor, right? So which patients I'm not going to use the SGLT2, not going to use the Findranon, like those who have a hyperkalemia, those who potassium is running more than 5.5, but it is safe to use them when the potassium is around 5 and continuously and periodically monitor their serum potassium. If the serum potassium goes up to more than 5.5, you can stop the drug and restart the drug. And there are ways to lower down the potassium. We know that the potassium lowering drug, which we use commonly in the CKD patient, like Veltassa or Lokelma and all that medications. So the Findranon also has shown great effects in slowing down the progression of kidney disease. And that's why I say this era is not as depressing as 20 years back, because we have a few excellent drugs. I did not touch GLP-1 agonist, one, because I don't have too much time left, and the second, we do not have a robust kidney-related data, but that data should be out like in few years, and then we're going to be including that too. So summarizing this, I can say, the proteinuria is a very important marker. Focus on the protein leakage, diagnose it early. At initial stage, we understand, you cannot refer all the patients of the proteinuria with a normal or little abnormal GFR, but those who have more than 300 milligram, I think the nephrologist should get involved. The patient should be considered for the new medications, and early diagnosis and early referral is the way to go. And I'm going to sum up this slide, which Dr. Wilson already discussed, and I'm going to conclude here and open for the questions.
Very nice, Parag.
Thank you.
Parag, you mentioned about combination therapy. While we're waiting for questions, I might just bring you up to date a little bit. A lot of people are questioning, what's the effect of these medications when you combine them? Well, we've been able to do we've been able to do analyses, post hoc analyses, and showed that there's that both of them work well together, and they seem to have a greater effect on reducing progression of kidney disease and cardiovascular events. But I can tell you that there currently is an ongoing trial right now called Confidence, which is actually still actively recruiting, where they're looking at the combination of